What day is it today? It is February 19th, Wednesday, and this is House Healthcare. This morning and today, all day, we're going to be hearing from various organizations, advocates who have some budget requests for us. And we'll be keeping track of all of these, so when we start making our budget recommendations to House Appropriations, we can go through all of these. So first up, we're going to have Jessa Barnard from Vermont Medical Society. And it's my understanding, Jessa, that you are actually representing a couple different people.
I'm trying to. I will do my best. Yes, we're trying to keep our time efficient. So yes, Jessa Barnard, the Executive Director of the Vermont Medical Society. I have submitted a one-page outline of what we're talking to you about today, not just on behalf of the Medical Society, but the Vermont Academy of Family Physicians, the American Academy of Pediatrics, Bi-State Primary Care, Health First Independent Practice Association, Vermont Nurse Practitioners Association, and VAWS. And here to really focus on primary care this morning and primary care funding needs. Primary care, you all know, you've heard, has had challenges for years being sufficiently funded in terms of base funding and workforce initiative funding. But the main piece I really want to highlight today is a newly formed one-time cliff for 2026 because of the timing gap between the ending of OneCare Vermont programs and the start of the AHEAD model. So I know you've heard this, but just to sort of go back over the background of the current all-payer model with Medicare that works with OneCare Vermont, that is coming to an end at the end of 2025. And then the newly signed agreement to enter the AHEAD model, which includes primary care funding and a per member per month kind of monthly payment for primary care, won't now be starting until 2027. And not starting the AHEAD model also delays Medicare continuing their contributions to the Blueprint for Health program. So there will be a loss of about $15 million for primary care in state fiscal year 2026. And I'll break this out in more detail and trying to hit the right level of detail. Happy to sit down with anybody individually and really go through the granular numbers, but I will lay out the sort of categories of funding.
Woody has a question.
Yes.
Yes.
Question regarding the OneCare program as it departs. Didn't the Green Mountain Care Board provide funding for it to continue on until the AHEAD model comes on board? And wouldn't those funds currently help primary care in your region?
So not entire, not really. There's not going to be new. So OneCare, and I'll despite what anybody may think big picture about whether it was successful or not, one thing it did do successfully was combine Medicare, Medicaid, and some commercial and hospital dues into one pool to really help support primary care. And I'll go into a little more detail about those programs. Those revenues to support and to then go out to primary care will not be coming in and going out in 2020, state fiscal year 2026. There may be some, so OneCare will be allowed to kind of continue for that year, but really to wrap up their 2025 programs, because there's often kind of lag, like there are some payments they make that are quality-based payments. There's often kind of wrapping up of work that really the year after the program year has ended, but there will not be new dollars supporting primary care through these programs in 2026. So it really is a on-off switch that is turning off, except again for some sort of wrapping up of 2025 year. And I want to be clear that so we believe this could be a one-time funding ask because it really is for 1 year. The issue is it's a calendar year program, and so it will potentially span 2 state fiscal years. So our ask is actually half of the full need to go from if I get my dates here right, June of, the 2026 June to December, and then there would be some of the 6 months in the following year to get the full 2026 year. I always get this date. That math always confuses me. I'm not a math person, but it's it's half of the state fiscal year covers half of the calendar year losses. And our assumptions of the funding need build in Medicaid continuing their contributions, because so these programs, as I mentioned, are Medicaid, Medicare, and dues funded. Our understanding is Medicaid has not backed that funding out of their budget requests for state fiscal year 2026, so that Medicaid could continue their contributions to these programs. So really the amount we need to backfill, or the state would need to backfill, is the Medicare and dues contributions pieces. So let me tell you a little bit about which these programs are, so you can actually picture where this money is what it is doing. It is going to the OneCare's Population Health Model program. This is a program that funds all OneCare participating primary care practices, which is a lot around the state. I have a link to the full list. And under that program, there are base payments that a primary care practice, and actually, just to be clear, goes beyond primary care, goes to some designated agencies and other community agencies as well, base payments, and then bonus payments for things like primary care programs we want to incent, developmental screenings for children, wellness visits, hypertension management. They've set quality measures that you have to meet. So the biggest chunk, for about 4.6 million, would go to continuing that program. And then another really important piece goes to what is called the Comprehensive Payment Reform Program. That is the prospective payment, so sort of paying monthly to independent primary care practices. There are 19 of those currently, and it, again, rolls up their fee-for-service. It kind of chunks together from all the payers their payment for care they're delivering, plus some add-on payments to sort of incent high-quality care, keep them sustainable. And our ask is really just to hold harmless all of these participating practices for the state fiscal year until we're at the ahead model. It would assume keeping the same sort of participation, the same payments that went out in 2025, just continuing for 2026 until we get to the ahead model. So that's sort of how we built that 5.5 million need to continue those two programs.
I think I'm a little confused.
Okay.
Okay, so let's start at the very beginning. Actually, no, let's not go back to the beginning. Let's start where we are today.
Yeah.
So the ACO today, February 19th, are they still making, when does the ACO end? And when I say, are they still making payments? Are they still making payments from Medicare, Medicaid, and the commercial payers?
Yes, everything stays in place until the end of calendar year 2025. So this funding, this is where my math was. This is to continue from January 2026 to June 2026. So it's it's the second half of the 2026 state fiscal year.
Okay.
Right? Yeah.
So we're looking to replace the Medicare portion of what the ACO currently distributes
Correct.
for that 6-month period of time for fiscal year 26, the second half of fiscal year 26.
Correct.
Okay. So now so as I understand the ACO, there's a couple different models. So Blueprint.
We'll be getting more to Blueprint too, but yes, Blueprint's a separate program, separate funding stream.
I'm just thinking because at one point, didn't Medicare discontinue payments to Blueprint, but because we were in the all-payer model, they agreed to continue the Blueprint payments through the ACO. So currently, the ACO is distributing the Medicare Blueprint per member per month.
Correct.
Is your ask to continue that?
That is also, that is yes, that is also one of our asks. That is our third bullet. And that is in the governor. So that is a separate funding stream that would also, Medicare will not be making contributions to that in 2026 either.
Okay.
Because they agreed in our negotiations with CMMI to continue that if we were in the AHEAD model, basically only. That was really our only path to continuing those funds. So that would, we hope, if things go according to plan, start back up in 2027. But there is also a year funding gap from those funds. That is actually in the governor's state fiscal year 2026 recommended budget.
Okay. So for those 19 practices, though, that are on a prospective payment system, wouldn't they just revert starting in January of 26 to fee for service with Medicare?
Yes, but that does not recreate the whole program. They are actually currently paid above fee for service by participating in that program because it's pooling Medicaid, Medicare, and hospital contributions that actually get them above fee for service rates. So it's not, so there's two benefits of being in that program. One is being paid prospectively and sort of in a bundled payment. The other is actually getting paid above fee for service rates. And there would be no, without some kind of mechanism or funding to do that, that would also be going away.
So is your request for funding to continue the prospective payments or just have an allowance for above fee for service?
I think ideally both. We are still in conversations, and OneCare and DIVA are in conversations about what, because they're basically, without the ACO, there will need to be a mechanism for making these payments. Like somebody actually needs to pay to continue or distribute the funds to continue the population health model and CPR payments. The most obvious channel to do that would be with DIVA. DIVA also used to do the Blueprint payments, obviously has all the payer contracts with the practices. So I think I don't think we have that level of detail yet of knowing exactly how and what that distribution would look like. But the goal would really, ideally, if possible, be both. And Medicaid has been participating in these programs, right? Medicaid's been participating in CPR, participating in population health model program. They've sort of been giving that money to the ACO to distribute, but they know how they've been making those contributions. And ideally our hope is that working between OneCare and DIVA, they could make a somewhat relatively smooth transition to DIVA continuing those programs for that year. So did I answer your question?
So in the governor's recommend, they have 10.8 million in the lost Medicare payments to Blueprint.
Yes.
And
SASH. Yes.
So I think that I was led to believe that was the entire 6 months of what Medicare would have paid under the Blueprint. But is it not?
It is what Medicare would have paid for it keeps that piece, it keeps their Medicare's Blueprint and SASH payments whole. It does not fill the other OneCare programs that will be stopping. So it fills part of the gap, not the full gap. It fills the Blueprint gap only. But then there were the other programs that were being paid for partly by Medicare fee for service being pooled in, partly by hospital dues being pooled in, DIVA dollars being pooled in. The DIVA dollars, again, we think are continuing, but that program there is not in the recommended budget or those programs. So that would be another 5.5 million gap for that half fiscal year.
Thank you.
So can we go over these numbers again?
Yes, please.
Yes.
Exactly how much do you want and where is it going? So the first one I see here is
Yes.
$5.5 million.
Yes,
That's for primary care funding.
yes,
Yeah,
yes,
okay.
yes.
And is there another $5 million?
Then if you go down to the third bullet, that is the 10, sorry, there's not another 5.5. There is then a 10.8 for the blueprint. I believe the state, that's a matched amount. I think that's the full global commitment amount. I think the state is about 4.5 or $4.6. That is in the governor's recommend already. And we support keeping that in.
So we don't
The
need
budget.
to do.
You don't need to add that. That's not additional. That's in the recommend. The new not in the budget ask is the 5.5 for the primary care, for the population health model and the CPR program. And we believe that those could be that that these are not base funding requests. Ideally, we hope ahead comes in 2027 to support primary care. These are one-time funding asks with, but we may be back next year for the second half of that 2026 one-time
For
ACO gap. Because again, that 5.5 is half the calendar year. It's really it's basically an 11 million calendar year need for the ACO programs continuing for one calendar year.
Hopper, were you all?
I'm done.
Could you do me a favor and explain the difference between primary care and patient-centered medical homes?
Yes, patient-centered medical homes are a subset of primary care practices in Vermont. The majority, I think about 70% of primary care practices in Vermont participate in the Blueprint for Health. It's actually a national designation. You have to go through what's called the NCQA, National Quality something accreditation. You meet national criteria to become designated as a patient-centered medical home. And then you get additional you get dollars through the Blueprint for Health by qualifying as a patient-centered medical home. And Blueprint payments, there are various streams within the Blueprint program as well. Some go directly to the practice to kind of support the staffing, the time needed to get that patient-centered medical home designation. That's sort of a payment directly to the practice. The other big bucket is for the community health team staff. So that doesn't go to the practice, that goes to sort of an administrative entity in the community that then helps staff primary care practices with community health workers, social workers, case managers, staff to help surround the patient and practice with meeting all of their other case management needs, social determinants of health needs. So the patient-centered medical home payment is a piece of it that goes directly to the practices. So that is continuing under that third bullet about the Blue Medicare payments. It continues the community health team dollars and the patient-centered medical home dollars and the SASH program. That's the piece that's in the governor's recommended budget.
Hope that helps the people watching this. Thank you.
Ari?
So it sounds like there's administrative tools and reporting that if you're in the ACO, that's covered, but if you're not, then that's left to the practices to pull together reporting.
Yes, right. There could be practices that are patient-centered medical homes that are not in one care. There are the reporting requirements the state has really worked hard to try to align them, but there are some that, not sure if I'm really answering your question. Regardless, to get that NCQA national designation to be a patient-centered medical home, there are reporting requirements that all of those practices need to do. If you are also in the ACO, there are also ACO reporting requirements that are generally aligned, but the ACO may help gather that quality data. Is that helpful?
So there
Yeah.
could be a gap between ACO and AHEAD for some practices.
Yes. And actually I will, I did not put that on this sheet because I did not want to overwhelm you, and it's not a budget ask, but actually another really big lift and gap for practices in 2026 is going to be that Medicare has a whole quality payment program called MIPS, MIPS. And that if practices have participated in OneCare is considered an advanced payment model under MIPS, which means practices and hospitals in Vermont have been exempt from MIPS. Because there's already quality reporting to participate in OneCare, because there's quality reporting within the ACO, Medicare has basically said, great, that counts as reporting on measuring and reporting on quality. We kind of defer that to the state. You've counted as an alternative payment model. That also goes away. And so now every primary care practice in Vermont, if they've been participating in OneCare and is now OneCare is gone, they will need to be reporting directly to the federal government in this new to Vermont practices, or new to these primary care practices, quality reporting program called MIPS, that comes with bonuses if you do well, but unfortunately for many practices, penalties if you don't meet their, and up to, I think this year, 9% reduction in your Medicare payments if you don't meet their quality measurements. So we've had some positive conversations with AHS. As you know, I think AHS is working with a new contractor to help with their transformation work. That contractor also has some of that funding and support for the contractor is to support primary care in transformation. And so practices will likely need a lot of help learning what this means to participate in MIPS, how to do it, what the measurements are, how to report them. And so we're hoping some of that contractor's work and some of the Blueprint quality improvement staff can help practices take on this work. So I don't want to emphasize what a problematic year 2026 will be for primary care in Vermont, between facing potentially reduced payments and this whole new quality reporting system. So we understand there are reasons why Vermont was not ready to enter AHEAD until 2027. There's obviously the whole hospital component of AHEAD that's very complicated, but from the primary care perspective, it's going to be a very challenging year. And I do want to mention, you will be hearing another speaker tomorrow in more detail, but some other pieces that are an extremely important part of the puzzle is workforce development and making sure we even have the workforce to provide primary care services if we can sustain our practices. So one program we're actually really excited about, this is some good news. I know you don't get good news very much, but there's really been a lot of work going on to create a new family medicine residency program. I actually have one of the physicians involved with starting the program here in the room, Dr. John King. So he'd be happy to talk to people afterwards, or he was here this morning. And Michael Costa from Gifford will be here tomorrow to give you more detail. But they've gone through the accreditation application process. They had their site visit back in January. This would be a partnership between FQHCs and hospitals to train family medicine residents around the state and keep them in rural primary care. It will become self-sustaining once they have their full class of residents in each year, because that brings federal dollars with it. But until that point, we are looking for one-time funding to get them to that point of being self-sustaining over 3 years. So again, they have some great, very helpful handouts. Michael Costa will have them tomorrow, I think, but we can also submit them with my testimony today. And then one other, I do want to mention a couple. I know I'm probably running short on time here, but I just want to make sure I cover the full range. There's also, your committee did some really important work a couple of years ago to establish a medical student incentive scholarship program. This provides scholarships to up to 10 third and fourth year UVM medical students who commit after their residency training to coming back to practice primary care outside of Chittenden County. 22 scholarships have been awarded. I believe they're in their application cycle right now. When you created the program, it had a sunset on it. So it would sunset in 2027 without removing that. And it also only had a couple of one-time funds put in to fund it. So that is actually a base funding request to keep this program going and remove the sunset. We think it's, again, extremely important to have this pipeline of folks coming back. If we can, and they haven't awarded the full 10 each year, but it's been close to that. And if, thinking about getting, even if it's 5, 6, 7, 8 new primary care physicians in Vermont every year is incredibly important. There is not we don't have data yet on where they have come back to practice because these folks are still in their residency training. So the sunset unfortunately did not quite line up when when we'll actually be having data yet on them coming back to practice in Vermont, but we will be starting to gather that soon because I think they would be in their last year of training now. And I would also, okay, one more thing, and then I know I'm throwing a lot of data at you. Oh, yes.
Well, why would we want to put a future doctor in a residency program in another state if we want to keep them here?
Because for various reasons, there may not be enough, they may not match. So it's a very competitive match process. So they may not be able to stay in Vermont. There are only a couple, right now, Vermont only has one. So again, this is a good pairing with the new residency program getting started. There's only one family medicine program in Vermont right now at UVM that has only limited slots per year. So they may not even match in Vermont. They may want to get other training, they may want to specialize, sort of have some additional training or try practice and, get training in a more urban area and then come back. So the real goal is at least get them back after they finish their residency. Some of the applicants may have stayed in Vermont for their residency training. But there's probably not we would basically fill the entire residency program at UVM with these students, or in fact, we would exceed it. If you're looking at the number per year of students who get this scholarship versus the current training slots at UVM, there aren't enough slots even if they did all want to stay currently.
Thank you.
Sure. Yeah.
Oh, yeah, I'm sorry.
It was poor timing for sure, because there's no data to show that. But what is the commitment exactly?
The commitment is for each, so they can reapply, they can get this scholarship for up to 2 years. So they could get it in their third and fourth year.
Okay.
It covers their in-state tuition only, not room and board. So I believe it's around currently maybe 35. Do I have this number right? No, it's probably around $50,000 a year. I was going to say not 35, 50, about 50 a year.
Mhm.
And then for each year that they receive the scholarship and that tuition payment, they need to commit to practicing in Vermont after their residency. So a year for a year.
Okay.
And there is some data, and I will say, so AHEC, the Area Health Education Centers, helps administer this scholarship. So I don't want to say there's no data. They know which students have received this. They know probably where they're in residency. They know how much they've expended to date. So they're certainly, if you wanted to get more into the details, we could get you. We have more data on the program. This was.
In previous years, how many did all of the physicians come back to Vermont once that had the scholarship?
So that's the data we don't have yet, because so a family medicine residency is 3 years and we're just awarding the fourth year now. So they're all still in their residency
What
program.
about the ones that were in there before? AHEC's been around for.
AHEC has done loan repayment for a long time, and there is not a scholarship for medical school tuition, but repaying loans after people come back to, regardless of where they've trained. If they come to Vermont to practice, you can apply for loan repayment. Loan repayment, I believe, is successful. Loan repayment also helps keep folks in Vermont. So we do know this type of program is successful. One last piece, so the last piece I do want to mention, just to make sure people are clear on the different Blueprint programs. And I know you've had a presentation on the Blueprint from John Soroyan. I'm sure he could come back and go into more detail. There is also the expansion pilot that was really focused on social determinants of health, mental health, substance use disorder needs. It's been very successful in hiring more community health workers and getting embedded staff and practices to help with screening for mental health, social determinants of health needs. That is not funded at all in the governor's recommended budget. So that was a 2-year pilot we are in the second year currently. What the governor's recommended budget does have is language saying the pilot can continue for a 3rd year, but with no additional funding. We don't know, we've asked, we don't know yet if there is any carryover funding. So if there is any carryover funding, that could be used, but there is no additional funding built in. That has been fun. And you heard yesterday from Dr. Brina Holmes that the Dulce program is part of this pilot also. So that was funded in the pilot at 4.6 million in state dollars per year. And 635,000 of that went to Dulce. I think you had the question of how much Dulce was receiving. So again, that's been a 4.6 million state funding per year, 635 of that going to Dulce per year. And there is none in the budget to continue that program. And that has been really important to support, to sort of wrap around primary care services for patients and the practice staff.
And then Woody?
I'm just curious, when are you going to know whether there's any carryover funding?
I might suggest your committee might receive quicker answers to that than we do asking. That would be a question for Agency of Human Services, in terms of what they have left from last year. So I know they last we asked, they are working on that number, but I don't know if they have an answer yet. We'd be happy to ask again, but again, sometimes you get quicker answers from agencies than we do.
And then Mark?
Pilot program.
Yes.
When does a pilot not be a pilot?
Well, you will see, we put that in our category actually of base funding. Our first wish would be that continues on an ongoing basis, that we think that pilot has been very successful. It is really expanded. It is increased. And actually, I don't know that you've had the exact same presentation. Dr. John Sorian did do a presentation in the Senate Health and Welfare Committee, specific data on the pilot of how it has increased screenings in primary care practices to almost 98% of patients now getting screened for mental health, social determinants of health needs. They've hired over 60 new FTEs to work with primary care practices. We believe it is meeting the goal that was set up with the pilot, which is expanding screening of patients, referrals, brief interventions. So we would love for it to be an ongoing program. If that's not possible, at least continuing another year of the pilot.
Okay, was the plan to have the state pay to continue that if it was successful?
I don't know that I can answer that on behalf of the state. I can say that the state did commit to fully funding that program for the first 2 years. So that was all, so that was a program that did not have Medicare or commercial match. It was all Medicaid and state funded.
Right.
Whether that was their intent from the beginning, I can't speak to that. I would hope if it's very successful, it would be fantastic to have additional funding sources for that. But that was the way it was set up, at least initially.
All right.
I'm trying to keep track of, for each entity that's testifying with us, how much was in the governor's recommend. So was there other recommend for any of these items?
So the one piece in the governor's recommend was filling that 10.8 million in Medicare payments to the Blueprint and SASH.
Do you remember?
So that is the third bullet on our handout. It is, I believe, I want 4.5 state dollars, I think, but it's 10.8 total because it has global, that's part of the global commitment.
So you're requesting 10.8 million?
Request, keep that in the budget. We are happy with that we are happy with that request. We support it. Please keep it in.
So I'm just gonna copy paste that.
That is not an additional ask. That was in the,
But everything else?
Everything else is not in the governor's recommend.
Thank you.
Thank you.
I have a question around MIPS.
Yeah.
So if a NCQA qualified credentialed provider who participates in Medicare, if they do not participate in MIPS, you mentioned like at 9% cut? So is that 9% off of the participating fee for?
MIPS is still a fee for service program. It's still built on top of fee for service. So if you are a provider who is supposed to, there are exemptions for really small providers, but if you are eligible and should be participating in MIPS and just don't, I believe, I don't know that, I think that, I think you'd fall under that 9%. I don't know if there are additional penalties if you don't report at all. You know, if you should be participating and you just say, forget it, I'm not doing this, is that even more of a, I actually don't know I would have to dig into the consequences of that, but I'm sure there are. Yeah, and then there are also penalties if you participate but don't meet the quality thresholds that they've set.
There's a lot in here contingent upon, you know, the end of the ACO getting us to a head.
That's a gap.
What if that doesn't happen? And rather than this, and I'm sitting here.
Yes.
Rather than that, what can we do to support primary care rather than feeding them little bits of money?
Mhm.
I mean, you know, just, I get, and you had said something about, you know, the blueprint payments through the ACO that they receive for the patient-centered medical home, which is money that they're given to administer the program and report on the quality measures. We're giving them money to basically do the program, which isn't really supporting them. Or we're giving them money to report on what they're doing. We're not really giving them money to support what they're actually doing.
Well,
What happens?
yes, I can answer that in several ways. One of them is that I didn't even really get to the last bullet is just the Medicaid rates in general for primary care, which Vermont actually does fairly well on our base Medicare payments for primary care. However, there is no inflationary factor built in. So on a longer term basis, we would really like to see inflation reflected in that fee schedule. It is a lower ask for this year only because of these other huge gaps we're facing. So our top priority is let's fill the immediate 1 year gap. If we are not moving to a head, if I could sort of wave my magic wand, what I think would be a really great solution is one kind of bundled payment for primary care, like actually that AHEAD is proposing, is a $17 per member per month from Medicare for doing primary care, doing what we want practices to do. It's just here, there aren't actually a whole lot. You would have to participate in the blueprint to be eligible for that 17 payment. That's kind of the primary care program that CMS has said, yes, Vermont's already doing advanced primary care. You're doing a good job. We're not going to make you do more. If you're doing the blueprint, you would just get this payment for every Medicare patient. I would love to see a Medicaid component. I'd love to see a commercial component. Can we just match that 17 from everybody? That would probably be a huge step forward for primary care in Vermont. I think we're in such a unknown space right now. Are we really moving to a head? Our top priority is, well, everything on paper is saying we are. So let's fill this gap till we get there. It gives us another year. It gives us 2026. If AHEAD goes away, that gives us some planning time to say, okay, we're not working towards the 17 per member per month. What are we working towards? What do we want that payment to be to support primary care in Vermont? I think we have all the bones there. We have an amazing blueprint program with quality improvement staff and central planning staff and people on the ground in each community. I think a lot of that structure is there, but what do practices actually need? So that could help us get there. That could help get the funding streams out. And then what do we ask primary care to do for that, if anything, or maybe we say blueprint is the program. What should we pay to sustain sort of wraparound primary care services in Vermont? It feels like we're in such a contingent place that we have not. We can only really plan for one thing at a time, really. So we're planning, let's get to AHEAD. If that does come off the table, then I think we'd have some time to make the contingency plan.
Great, thank you.
Thank you so much. Thank you for your time.
All sorts of organizations.
I tried. I'm sure you may be hearing from them individually too, but thank you so much. Thanks.
Thank you. You want to come on up? I'm sorry, we're running behind. I was too.
need to see my statement, but I do want to share my screen so you can see the piece I want to share with you. Here we go. You can see it, sorry, I can tell it's behind me. Thanks for inviting me. I really appreciate it. I did send the committee a memo with a few of our asks for funding items that we'd like you to support. The only one I really am going to address right now is your possible support in your budget memo for cardiac emergency response plan implementation funding. And I will play a short video if I can, but just to forewarn you, I am technology challenged, and so we'll see how it goes. But I'm Tina Zook. I'm the Government Relations Director for the American Heart Association in Vermont. And again, thank you. The survival rate for out-of-hospital cardiac arrest currently nationwide is only 10.2%. Already, I felt that was just abysmal. Vermont's even worse than that. We just discovered recently the American Heart Association releases its statistical update with all kinds of cardiovascular disease facts. And as you'll see in my testimony, in Vermont, only 7.5% of cardiac arrest victims out of hospital survive. And that means more than 92% of victims die, which is just terrible. One of the reasons survival rates are so low is because only about 40% of the people who suffer a cardiac arrest actually have people step in, lay responders, to provide help that's needed before emergency responders even arrive. And Vermont's rate's likely even lower because of our rural nature and the time it may take for even really great first responders to arrive. Geographically, we're challenged in places. We're working to pass legislation. You probably all heard us talking to you a couple of weeks ago about cardiac emergency response plan legislation that would ensure both in schools and school athletic events have cardiac emergency response plans. Plans like these can more than double and sometimes triple survival rates by enabling a trained lay responder team to take action before EMS arrives. The plans create an emergency team that's CPR trained. They have AEDs well placed and publicly accessible, not locked away. They make sure the devices are maintained so the batteries are checked so it's actually working when you have to use it. The plan is practiced with a drill once a year, and the team integrates with EMS, as simple as saying, this is what our plan is. What do you think? Here's where the AEDs are. And if an event should occur, that there is that run through with EMS about what actually happened and what might be improved. While our research has shown that about 211 schools in Vermont do in fact have AEDs, not all do, and only 84 schools responded to our survey that they had cardiac emergency response plans. Just as quick background to that, the State Department of Health requires any entity that has an AED to report it with them and register it with them, including schools. And so the 211 is schools and school districts, which is great. Depending on, I always kind of grapple with what the actual amount of schools in Vermont is. So it's over 300 for public and another 80 something private. But so 211 is great that many have AEDs. I feel that some really aren't on that list. But we want to make sure they all do and not only have AEDs, that are CPR trained. It's not good enough just to have an AED hanging on the wall if people don't know what it is and don't know how to use it. Or worse, it's locked away and you can't use it when it's time to. So we are asking for your committee's support today for our budget request of $150,000 to create a grant program for Vermont schools most in need of resources to help implement cardiac emergency response plans. This funding will help ensure that there are trained lay responders, especially in rural areas, bless you, where EMS response times might be challenged. It could be used for AEDs and CPR training. We also heard from schools it would be helpful if they could even pay for things like when you use the AED, you get 2 sets of pads to replace pads because they're not necessarily cheap. The funding amount is based on an estimate of what it would cost to provide AEDs and CPR training to a quarter of Vermont's Title I schools There's about 194 Title I schools in Vermont. $3,000 is kind of our per school estimate that roughly, that would be like 2 AEDs and some CPR training. Since many schools, as I mentioned, already have AEDs in the state of Vermont, we didn't want to ask for funding for all of them because frankly, I don't think it's needed. We feel that this amount would be a good place to start so that if there's any, I'm not sure we could do it, we don't have the resources, that there is some funding to start with, that schools who have needs and they might not be able to pay for these on their own could actually go to this well to get some grant funding to help either get CPR training costs covered or AEDs. And why schools, right? Why are we looking at schools for this? Cardiac arrests do happen at Vermont schools. 24 have happened in the last 10 years. And 40% of the cardiac arrests that happen to youth under 18 are sports related. And obviously our schools have sports events taking place there. It makes sense to be prepared because emergencies will happen. Sometimes it's because of a blow to the chest, like any of our football fans here saw with Buffalo Bills, Damar Hamlin, when he got tackled and he had a cardiac arrest on the field and was revived because everything went right there. They had a great chain of survival. CPR was provided and an AED was used on him, and then further care at the hospital. But cardiac arrest might also happen due to an undiagnosed heart condition, like what happened to 16-year-old Milton sophomore Dominic Barcombe, who collapsed from a cardiac arrest just minutes into the basketball game against Spalding High School on January 3rd. So super recent. He's literally living proof of the power of these cardiac emergency response plans, because in Dominic's case, the Spalding athletic trainer and 2 coaches got their AED, performed CPR, and they had him revived before EMS even came. That's amazing. That won't happen everywhere. Not all schools are ready for that, and we want to make sure that it can. Now, so here's the technology part. So I hope this works. I feel like Dominic's story can tell you the importance of this far better than I can. He's kind of been a superstar in the media because his story is so amazing. So I'm going to pull it up, and I hope you'll bear with me. It is only 3 minutes, and it's a really great 3 minutes.
Unmute the room and then unmute
Yeah.
you. Okay.
Gotta get out. You don't need to hear that. Watching that, but I really ask you to remember his mom and his grandpa in that. Because what if Spalding didn't have the AD? What if their staff wasn't trained? Right? They got to say, your son, when she got there, he was just starting to come around. It could have been a much different scenario. So it may not always be a youth that needs help in these situations. It could be a parent, a coach, or an official. And it has been in various other instances in Vermont. All these lives are worth the investment to ensure that schools are prepared. Please support our request for $150,000 to help schools prepare for cardiac emergencies. It's such a modest investment. We're not talking millions. Yeah, it's a really small amount. And it could literally mean the difference between life and death. So I appreciate your time. And I just wanted to give you a quick update too. Little things like this do make a difference that you do. Last year, we asked for a really small amount of money, $30,000, to provide hands-only CPR kits to some schools across Vermont to help implement the law that was passed 11 years ago to require hands-only CPR training in schools. At the game that you saw there against Milton and Spalding, we had asked the Principals Association with that appropriation, what schools make sense to give it to? Those are two of the schools on the list. It was very cool to hand them those kits at that game because all those two schools, a lot of people in the stands watch CPR in action. And so it's top of mind. And because of the kits, through the funding you provided, a whole bunch of people are now interested in CPR and will be trained. So that's it. And I really appreciate your time today. I'm happy to answer any questions.
That's a silly question, but it's not silly. What do you mean hands-only CPR?
Yeah, so there's, you can get certified in CPR, and that includes the whole shooting match with rescue breaths, the traditional CPR, with the chest compressions and rescue breaths. Hands only is just what it sounds like. It's just hands. There are no rescue breaths. And if it's performed early on in a cardiac arrest, it's just as effective as with the rescue breaths.
Oxygenated blood.
Correct. And so, and it's, a lot of times people are just scared. I don't know what to do. I haven't been trained in CPR, that kind of thing going on. And so just that quick, we did a little tutorial here in the card room a few weeks ago, just so people get the feel of it, right? Because as long as you push deep enough and rapid enough and soon enough, it gets the oxygenated blood going, as you said. And it's very effective, and it takes away that fear factor a bit.
Yeah, because you don't know what you're breathing. So I think that's a real resistance. So I think it's a smart idea to remove that.
Yeah, and in some cases, the rescue breaths and Representative Cordes actually has the medical training that I don't. Could talk about that, but there are cases where that really is important. But this is a way, at least, to get a lot of people to act in an emergency.
I was just wondering if that took place at Spalding, does Milton do they have AEDs and do they have a cardiac emergency response plan?
I don't know the exact plan. If they have AEDs and they are working on a plan, so I don't know if they had a plan in existence or not, but they definitely are now because it's obviously we know that it's needed. And so we want to make sure that the cardiac emergency response plan isn't just we have an AED and we're ready to go. We need that team because people may say, oh, well, we have a school nurse and she's CPR trained, but many schools don't have a school nurse every single day. It might be Tuesday and Thursday. And so making sure whoever you decide the team is for your school, maybe it's your principal, your facilities manager, your school nurse, your PE teacher, whoever it is, that you're aware. So when that time comes, people aren't fumbling around to say, oh, where's Nurse Smith? I don't know where she is. And precious time is lost because you really have maybe 10 minutes on average, because every minute that goes by without defibrillation and CPR, the chance of survival drops. If people are wasting it, wondering where the AED is and who's going to help. It's not helping the victim at all.
Wondering if Dominic's life depended on whether it was home or away. The game.
Yeah, well,
They were both there, everything was okay.
yeah, and his mom, there was a documentary that was done. The Vermont Coyotes are amazing. They're Vermont's new or soon to be new semi-pro basketball team. Did a documentary about his story, and his mom says in the story, "I'm glad it happened at school because if it happened at his house, he wouldn't be here because she wasn't CPR trained." So that's our message too. Like everyone just needs get CPR trained, but these will help in school situations.
Well, thank you, Tina. Thanks for coming.
Thank you very much.
Thanks, Tina. And we enjoyed having him in the building. Was it a few weeks ago? when he
Yeah.
was here? That was wonderful.
Thank you.
Thank you.
Jill, you want to come on up?
Sure, thanks. Okay, I'm doing better. Well, I had tech problems the last time I was here, so I've managed to join without messing up the audio. So now I'm gonna try to share my screen. Oops, looks like I need permission to do
Oh, you're
that.
up on the screen.
There we go.
You're being too, do that.
Not what I want to share. There we go.
It's like she's in a warmer climate.
No? Try again.
The heart diffusion. This, it's talking shape, but I don't think.
Oops. I'm an idiot. Okay, here we go. You can see that, yeah. Great. Hi, everybody. I'm Jill Olson. I am the Executive Director of the VNAs of Vermont. So I represent Vermont's home health and hospice agencies. So I was here earlier in the session. A couple of the slides in my deck you've seen before. I just wanted to kind of orient our conversation. Thank you very much for having me today. This committee's been very supportive of home health in the last several years. You've supported several increases for us as we've tried to get our skilled home health rate up to Medicare rates. That's what we're trying to do, get our Medicaid rate to match our Medicare rate, standard Medicare rate, not Medicare Advantage. I'm going to give you a little bit of an orientation, just a quick reminder of sort of who we are and what we do, and then talk a little bit about the payment and why it's important. So just a reminder, home health agencies in Vermont provide kind of 4 major types of care. What we're mostly talking about today is the skilled home health that we provide. So that's medical care at home, usually after a hospitalization. So maybe after a cardiac event, as we were just hearing about, or after a surgery, or other kind of hospitalization. So we're talking about our Medicaid skilled home health rate. In Vermont, we have also tied to that our high technology rate. That is for serving people who need equipment like ventilators at home, live with ventilators. Usually there's a pediatric and an adult program. And that's like, 8-hour shifts of nursing care, really to watch for anything going wrong. So we've tied that and our pediatric palliative care to our skilled rate. So they kind of all have moved together over the last several years. So they're in sort of different buckets. Down the hall, we talk about long-term care. So that's the services we provide for people who need help just being independent. So they might need help with bathing or dressing or that kind of thing. People who would otherwise be in nursing homes. What I always say about home health, particularly in a place like Vermont, is really everyone that we're taking care of is someone who would otherwise be in a more expensive setting. And it saves money right now today, not in the future. So it's cheaper right now today for people to get care at home than it is to get care in a hospital or in a facility. To be clear, we need all levels of care. Not everybody's appropriate for home, but for those people who can be cared for at home, it is definitely our least expensive option. And hospitals in particular are relying on home health to take discharges. We take, let's see, I have a new number. We're taking about 14% of hospital discharges right now. That's new data from last year. So nursing homes are taking about 18. So imagine if we did not have skilled home health taking discharges, we've already got a problem with people not being able to get discharged on time. This would be much worse without skilled home health. partly because of the benefit itself, what Medicare normally covers, home health serves a really vulnerable population. So it's mostly people who are pretty frail, who are disabled, who have multiple chronic conditions. As you see, of the people that we take care of, so 86% of beneficiaries who use home health have 3 or more chronic conditions. 9% of Medicare beneficiaries in the general population have that many. So it's often the more complex people who home health takes care of. Okay, so there's a lot going on in home health that is making it harder for agencies to provide services. You heard about all of these the last time I was here. I am going to just give you my quick rundown again. So we've got the cost of travelers. So sometimes we need traveling nurses, contract nurses. They're super expensive. We pay staff to travel, so we pay them for mileage, but we don't get reimbursed for mileage. And this is part of why rural home health is more expensive. We drive more miles. And we also pay people for what we call the windshield time. That's time as they're driving in the car. There's no special reimbursement for that. We have the workforce shortages, wages, salaries, benefits, and historically low Medicaid reimbursement rates that have been largely inconsistent. But over the last few years, you've actually really improved them. You've really improved our Medicaid rates for skilled services. One of the things that's happening in home health right now is that it used to be that we had Medicare margins, high Medicare margins, meaning Medicare paid us more than we needed to take care of Medicare patients. Sometimes that's still true if all you look at is our straight Medicare. Medicare likes to look at just Medicare. So, and this is a problem that spans across administrations. This does not seem to get better no matter who is in charge. Medicare compares to standard Medicare rates. Medicare ignores, when calculating whether or not home health agencies have enough money, Medicare Advantage, for example. So lots of beneficiaries have migrated to Medicare Advantage plans that many times pay way less than standard Medicare. And there are no federal rules saying they have to pay us equivalent to standard Medicare. There's just nothing that says they have to do that, and they often don't. And we're talking about large national corporations with whom we have no leverage. And there's no state regulatory body that's in charge of this process. So this is all a federal issue. It's essentially managed care for Medicare. And we have really minimal leverage. So we used to have margins available to support programs that did not pay cost. So Medicaid programs. So like our long-term care that we talk about down the hall, like skilled home health and other programs, there used to be dollars there. Home health has almost no commercial reimbursement. It's all government payers, almost all government payers. So we have a process where Medicare has been making what they're calling permanent cuts to our rate. So they put a new payment model in January of 2020. We were a teeny bit busy when that happened. You may remember our pandemic, but they also put in a new payment model on January 1, just before the pandemic hit. And a couple of years later decided that the rates were too high and started cutting back on that standard rate. And that's been happening over time. So we got a cut on January 1, 23, 24, 25. We expect one more next year related to this permanent cut. So you see, again, spanning administrations, it's been pretty consistent. Congress has not been willing to intervene in this. We keep asking. We also have, we had a lawsuit pending. We're starting over, our national association starting over with that process. It's basically a big fight about how to do the math. So that's really what it is. The scariest thing, and frankly, it's gotten scarier since we changed administrations, is that CMS has the authority to go all the way back to January 1 of 2020 and claw back the entire cut, going back all the way to the beginning. So they phased it in over time, which has been helpful in the short term, but it just means that delta between what the size of the clawback just gets bigger. So there's a big clawback hanging over our heads. We keep asking Congress to take it away, and they still have not. So far, CMS has not implemented that clawback, but they could at any time. They have the authority. So as I said, that's gotten a little scarier for us in recent days. So just taking a look at Medicaid, you saw this slide, I think, when I came before, but just a reminder. So this is a pie chart showing what we call payer mix. So what proportion of revenue is coming from what payer? So profitable home health agencies do a little sliver of Medicaid. That's the ones that are making money, don't do much Medicaid. In New England, home health agencies do not take a whole lot of Medicaid. In Vermont, it's a very big piece of our pie. That's partly for our long-term care services down the hall, but that's the reality of what home health agencies are doing. They're taking lower paying patients all the time. That is good for Vermont. That is good for Vermonters. It's just tough to make it work as an organization. So you may remember last year, Franklin Home Health closed. They closed about this time last year, March of last year. It hasn't reverberated through the state the way it might have because another agency took over their service area. They did not merge. So some people say they merged. They did not merge. That organization was too financially stressed for anyone to take them over. They closed fully. They no longer exist. That provider number is gone. And because we have a designated system in Vermont, different than any other state, that territory was designated to another agency. So functionally, a lot of things stayed the same. But the reality is a high Medicaid organization could not make it in Vermont. That's what that story says to me. So what we're trying to do, what we've been trying to do for a long time is get to 100% of Medicare so that our Medicaid rates match our Medicare rates. You have made progress on that. You've gotten us to 67%. So I'm going to get a little technical here. Some of you who've been here in years past remember that what we got to was 100% of our what's called our LUPA rate. That's a lower payment rate that is part of the Medicare payment model. I'm actually going to skip. So we have that. So Medicare pays us in this, they call it an episodic payment. So they pay us for 30 days of care, regardless of how many visits we do, with an important exception. So there's 30-day periods. There's 432 what they call case mix groups. So this is like a giant matrix, and lots of things go into the matrix. Your admission source, so hospital or community, timing, whether it's early in your 30 days or later, clinical groups. So is this a respiratory issue? Is this post-surgical? Is this cardiac? Functional impairment. So essentially how functional you are, how well you're doing. And then comorbidity, which basically means your other diagnoses. So they take all that stuff together, and that turns into these 432 categories. It's sort of like a hospital DRG, if you know what that is. And then there is a payment adjustment if the visits don't hit a certain threshold. So sometimes the threshold is 3, sometimes it's 4, sometimes it's 5. If there are fewer than that many visits in an episode, Medicare bumps us to a lower payment rate. It's a per visit rate. Medicaid has always paid us on a per visit rate. So Medicaid does not put into place all this complexity. And we don't think they should, and they don't think they should. We agree on that. It's too complicated for the size of our Medicaid program. We are not asking them to do that. But we do want to understand how we stack up against full Medicare. Because what we've done in this committee for several years now is just compared our rates to that lower LUPA rate, which has been good. We've made good progress, but not knowing how that compared us to true Medicare. Last year, you recommended a study to try to figure it out, and we did over the summer. We spent a lot of time with DEVA, with our financial experts, trying to figure out a way to kind of map this Medicaid model to the more complex Medicare model. And we all agree, there are a lot of back and forth. Well, it was a very amicable process, but it was just complicated. There were a lot of spreadsheets involved, that we're at the 67%. So we all agree on that. So what we want to do is make real progress to get closer to Medicare rates. So we want to get to 90% this year. That's what we're asking for. That's about $1.2 million in the general fund. Nolan, I have really complicated spreadsheets that I did not submit that I can share with you if that's helpful, just so you can see them. It shows different categories, but it's a really complicated workbook with multiple sheets, not conducive to presentation. This request does include commensurate increases to pediatric palliative care and high tech, which we've done all along. And again, we have this new methodology that's comparing our per visit fee schedule for Medicaid to this much more complicated Medicare fee schedule. So again, we've worked really hard in the state to do things like try to get primary care up to Medicare, and we've been working to try to get home health up to Medicare. There's no special money coming for us in healthcare reform. There never has been. So there might be under the AHEAD model opportunity under the East Fund that they're hoping that we get. And certainly the administration has really understood why we're important. But every time we plan healthcare reform, we plan to drive care out of the hospital with no plan for home health or nursing homes. I don't represent them, but that is also true. No plan for the settings that are going to need to receive these patients. We do it every time. And CMMI, the federal entity that is doing the planning, just does not really connect the dots between their model, where they want to drive care outside the hospital, and the fact that their primary arm at CMS is cutting us. There's no dot connection there. And if you ask them, they kind of swirl around the answer. They don't go straight at it. So we're not expecting, we don't think we can plan for anything but what we get under regular Medicare, regular Medicaid. That's how my members are operating. They're assuming that it's pretty much, we have our two government payers and we need them, and we need it to work with those dollars.
Ari?
I'm assuming there's nothing in the governor's budget for it.
Really good point. Yes, you can put a zero there. Yeah. Yes, there are dollars. There were dollars in the BAA for hospice. That's because there's a federal mandate to keep our hospice rates aligned with Medicare. And so they are. And so we don't fall very far behind. So I think it's maybe a $50,000 bump. We are so small. We are a very low cost, high value service. Yeah.
Leslie?
So let me make sure I understand.
Yeah.
You accept 14% of discharges from the hospital.
Yep.
Which means they don't go to higher priced
Or stay in the hospital.
or stay in the hospital. Is there a way to quantify the savings that you generate by accepting these patients and not have them go to the higher cost places?
I'm sure there probably is. It's even possible that some have done it. There's a complexity. It depends on the case mix of the people who they are. Yeah, I don't have that number.
Because in order to make
Yeah.
a case, I think we have to say, by sending them, having home health go, then we are saving X millions by not doing it.
Yeah.
That's what I'm wondering.
Yeah. Yeah. No, I don't know if that calculation has been done that way. We do have it for the long-term care. We do know it's about a third of the price for people to stay home than to get long-term care in the facility. Yeah.
I mean, just because it would offset what
Yeah.
you're asking.
Right.
Or, like a third left. Who knows, right?
Yeah.
That's what,
Yeah.
to make an
Okay.
argument.
That's helpful.
Any other questions?
Okay.
Thank
Thank you very much.
Coming in, Jill.
I appreciate your time.
Appreciate you coming in.
Sure. Yes, very much.
Okay, let's see if I can get out of here now. Okay, I did it.
We're gonna take a break, I think, right now until 10:30.